Well, now we are going to hear from Flight Surgeon Colonel Matthew Compton. And that's me in this room. And then in room 320, again, we have osteopathic manipulations in 4 different cases. That's over there. And we have 312 is over here. We have food as medicine for general health. So right now, please welcome Flight Surgeon Colonel Matthew Compton.
Hi, everybody. If it wasn't readily apparent by my green pajamas, I am a flight surgeon. I work here at Hill Air Force Base, and I'm here representing the 75th Medical Group, which is the organization on base that runs all the medical care, and also the 388th Fighter Wing, which is the organization on base that flies all the airplanes that you see overhead, or at least most of them. The first thing I would like to do is to extend a heartfelt thanks to you as providers and physicians in this community for seeing and taking care of our airmen when we send them to you. Our clinic is a primary care clinic only, so we don't have specialty care, and we often have to send people off base for your services, your surgery, lab, diagnostic radiology. So thank you for taking care of them. It means a lot to us. We are very appreciative of that. Keep taking care of them. Keep sending us the information back. It really helps us to take care of our pilots and our mechanics and all the people that we send to you. So I also recognize that I'm one of the few people that's keeping you from your weekend, and I was going to apologize or tell you I'll keep my lecture short, but it doesn't look like I'm keeping very many of you here anyway, so that's okay. We've learned that being outside is healthy for our lifestyle, and so that's what we should be doing. But hopefully, thank you for staying. Hopefully those of you who are still here will, I can share with you something interesting. Just a little bit about me. I'm actually much more comfortable in a one-on-one setting rather than up here on the stage. If I had Dr. Greenwood's wand, I would probably remove myself from the stage and place myself across the table from you, and we could share stories about what we do on a daily basis, and that interests me more than this. But here I am. I'm going to share a couple of things that we're doing in the Air Force as far as taking care of our pilots. My background, I'm residency trained flight surgeon. I did a family medicine residency in Omaha, and then a sports medicine fellowship at Rocky Mountain Orthopedics in Colorado. I've been about 14 years in the Air Force. In those 14 years, I've visited or lived in several states and countries, and it's been wonderful for me and my family. I actually have some local roots. I was born and raised here in Utah, graduated from Morgan High School, and also Weber State University. Go Wildcats, there you go. I did pre-med here, and so that set me up for a very fulfilling career so far. My job at Hill Air Force Base, I'm a flight surgeon. I take care of the F-35 pilots. All these jets that you see flying around are F-35s, and my job is to take care of those pilots, to make sure that they're doing well, make sure that they are happy, healthy, they're enjoying what they do, and if they do have a medical condition that comes up, I guide them through the process of getting Air Force paperwork and waivers through so that they can keep doing what they love doing. My only objective today really is to tell you about a program that we're implementing at Hill Air Force Base that helps our pilots to perform the best that they can and to recover from injuries as fast as they can. Colonel Nussbaum gave a talk last year at this conference about military medicine. He used this quote, and I shamelessly stole it from him and used it again in mine because I think it applies to what I'm going to talk about. It's from the Air Service Manual in 1918, and it says, "Today thousands of trained mechanics are working day and night upon the engines of our airplanes. Thousands of expensively trained riggers and sailmakers are tuning the wires and mending torn fabric. Thousands of hangars are provided to house the planes when they're not flying. A striking discrepancy is noted when we look about to see what is being done to take care of the infinitely more delicate organism, the man who flies the machine." And although I think that we've come a long way since 1918 in taking care of our pilots, we still have a ways to go. We're still trying to maximize the way that we take care of our pilots and make them as effective as we can. But it's difficult, right? Because a human is not a machine. A human has squishy bits. And a human has different motivations for recovery, and a human has different physiology that responds to medication and treatment for each individual. So it may not be feasible to cookie cut and to mass produce replaceable parts for humans, but we are trying to model that maintenance idea where we do regular maintenance, we make sure that our pilots are doing the right things, and a lot of these things are being mentioned in the conference on lifestyle medicine today. I like pictures more than words. I took both of these photographs when I was deployed in the UAE. As a flight surgeon, one of the cool things that I get to do is, maybe it was talked about early through the Navy talk, was I get to fly with the airplanes sometimes and on the airplanes, and so I have lots of flying time in Air Force jets, and this one happened to be from the back of a tanker where they do air refueling. The picture on the and the reason that I show these pictures is to remind me to emphasize to you and to tell you about the physical, the huge physical and mental stresses that we put our pilots through. The picture on the right is a formation of 4 F-35s that are flying, returning from a CDAG mission. CDAG stands for Combined Defense of the Arabian Gulf. And they fly in a formation like that all the way back. These pilots, they take off from the home base overseas. They fly for 2 hours across the Gulf. They do about a 3-hour loader time where they do their mission, and they fly back and do the reverse path all over again for a total of maybe 8 to 11 hour sorties. And during the 6 months that I was deployed, we did that every day. One particular pilot would fly maybe 2 or 3 of these sorties every week. And it was a tremendous strain on them. The picture on the left is an F-35 being refueled over Afghanistan. One thing I didn't know about Afghanistan before I went to the UAE and saw some of this happen is that they have these beautiful, majestic mountain peaks that are 19,000 feet in the northern half of the country, and that's what you're looking at there over Afghanistan. It looks treacherous, but it's beautiful. If you ask one of my any of my F-35 pilots what the most technically demanding task that they do in the F-35, it's this right here. It's refueling at night in a deployed setting. Because they're tired, they've already done this refueling about 6 times during the sortie. They have to use fine motor skills, and they have to concentrate so much on this, and the lighting is poor from the refueling jets. It's one of the most challenging things that they do, and it puts a tremendous strain on them mentally and physically. And that's not to mention that we put them in a jet that's in a confined space. A lot of these designs were implemented in a time when we didn't fly for 10 hours. We flew for half an hour or an hour at a time, and we still have the same setup that we did back then. And we put heavy equipment on them too, with helmets and wiring and a whole bunch of technology that is very difficult to mentally manage. And so what we're seeing, because of all these additional stressors, and also the aircraft are more advanced and more capable as well, and they can go faster, they can pull more Gs, they can stay up in the air longer. One of the things that we're seeing because of all these changes is our pilots are having a steady increase in musculoskeletal pain, and specifically neck and back pain over the past 15 years. And this is a study done by the Air Force Research Lab, which is at Wright-Patterson Air Force Base in Ohio. They also do an aircrew survey that talks about, it surveys pilots and said, hey, what kind of musculoskeletal pain and issues are you having? And some of these statistics are surprising and some of them are not. You'll notice that almost all pilots have some sort of neck or back pain or shoulder pain or what it might be. But some interesting things to me from this survey were nearly half of pilots said that they had pain that interfered with their duty doing BFM, or basic combat maneuvers. That's when they dogfight. So it changed the way that they approached their job in the air and the way they practice and the way they train. And perhaps most concerning are the bottom two. Half of pilots took themselves off the schedule and said, I can't fly today because of pain. Or even worse, 38% roughly said that they did have pain, but they never told their flight surgeon. They never told their doctor about it. Why don't they tell us? Because they're scared they're going to lose their wings. They don't know, they go into their doctor, and every time they go see a doctor, they have in their mind a risk that they'll be grounded and they'll lose their livelihood. So it's been an uphill battle to try to kind of disperse that way of thinking, but that's the way pilots still think to this day. We're trying to change that through this program I'm going to introduce to you. They decided, based on the statistics we're seeing for increased musculoskeletal pain, back pain, neck pain, and retention issues, pilots didn't want to stay in. They were being offered more money in the airlines. They were being worked over the coals from all the things that they do. And so they decided that they were going to implement some programs to try and help that, to try to help pilots' performance, to try to help them recover from these injuries. But it didn't start with pilots. In the beginning, it started with PJs, and PJs are the Air Force's version of the Navy SEALs. And this was probably 20 years ago, but what we saw from these operators and PJs and even the Navy SEALs and that group of special operators is that they had high injury rates. They're jumping out of airplanes, and it's not surprising, right? They jump out of airplanes at night. They do all kinds of crazy stuff. They carry 100-pound rucks, and they go for miles and miles and miles. And we started seeing just high rates of injuries in these particular members. My last job was in Tucson at Davis-Monthan Air Force Base, and I was a team physician for one of these groups of operators. And I was blown away by the number of people who came in their mid-30s with moderate to severe knee osteoarthritis. I thought, man, that is crazy. What are we doing to these operators? What are we doing to these PJs to make these chronic injuries and acute injuries come on so quickly? Well, because of that, they started a program called the POTF, the Preservation of the Force and Family, and it basically tried to model a Division I or a professional sports team. They had training rooms, and for example, the environment that I worked in, we had two or three athletic trainers, a physical therapist, a sports psychologist, a orthopedic surgeon, myself as a sports medicine doctor, and we all collaborated and we talked about every PJ who was injured every week and said, okay, how are we going to get this person back to doing what they love to do? And it was a collaborative effort, and it was much like a Division I athletic training room. And it started working. We were getting people back faster. We were getting people return to duty quicker. We were helping, hopefully, prevent some injuries in the future and retainability. But the pilot community latched onto that and said, hey, we want that. Our pilots are getting injured, long-term injuries, and even though they're not the same, we want to have something like that we can mitigate these injuries and keep our pilots happier, keep them their longevity, and increase their shelf life for the Air Force, which is another issue. So for the pilots, we call it the OHWS program, that stands for Optimization of the Human Weapon System. This is our space. Those are 3 athletic trainers. There's Corey and 2 others that work there with us. There's about 10,000 square feet of gym space. And so they have a workout facility, and they also have 24 access basically to these athletic trainers to work on them. The capabilities that they have are dry needling, soft tissue, a lot of the same things that physical therapy has, and maybe even more because they're specifically trained in some sports medicine techniques. My job is to clinically supervise these athletic trainers, not only from a clinical appropriateness and standard of care standpoint, but also because anytime we have a pilot go to someone, to a medical facility, we have to disposition that aeromedically. In other words, we have to say, well, with their condition, can they still fly the aircraft? And so that's part of my job in this OHWS program. And so far, it's been wonderful to work with. A couple of stats about that. So 3 athletic trainers. We do have 1 massage therapist. Something I'll foot stomp is that they're co-located in the same facility as the pilots do all their briefings, the same facility that the pilots do all their work in otherwise. And that helps tremendously because it's literally steps from where they do their everyday job. And they can pop in before or after a flight and get a treatment, either a massage therapist treatment or dry needling treatment or whatever it might be to help them mitigate the pain that they have before or after a flight. The scheduling is easy for them. It makes it so much easier for them. Like if a pilot has an injury before we had this program, it would be weeks to months before they could see a specialist, get an MRI, get treatment through physical therapy, and that was limited in its scope. So this has really changed the dynamic there, because the pilots now trust these athletic trainers because they see them every day, and they come into work and they do get their treatment and they go fly, and they're better off because of it. Just to foot stomp that, the fact that we have better access, last year, 2022, we had 4,150 encounters, and we're talking about the number of pilots at Hill Air Force Base is in the range of 100 to 150, and we had 4,000 encounters. The pilots are recognizing the value of this. They're coming in, they're getting treated, they're trying to mitigate the pain that they have. And so I think that alone proves the value of this program that we've had so far. The goals of the program basically optimize the human that flies the machine, as we alluded to in the medical service manual from 1918. We want to mitigate injury and get them back to flying and fighting as soon as we can, and training. And I think the area that we've been able to prove the worth the most is improving access to care and removing barriers to care. And that comes along with just being accessible, having streamlined transitions. So a pilot comes in and says, hey, I injured my knee. He immediately, an athletic trainer will recognize, this needs to see a physician. They'll call me. We'll have him in within days. And if we need to do further imaging or further diagnostics, we can do that within days to weeks rather than months, right? And then also just the trust that's developed between the medical community and the pilots. We've made a lot of headway in that direction, and the pilots know that if they come to see me or one of the athletic trainers, we're going to try to help them. We're not trying to hurt their career. It's not just Hill Air Force Base. We've got this same program at probably 60 bases across the country, and they each have their own model that they do. It's sort of the same with athletic trainers and physical therapists and different ancillary providers, orthopedic surgeons and people like myself. And it's difficult to align efforts because we're sometimes on another continent. This program may be implemented in Europe or in Japan or something, but we're trying to do the same things and have the same goals in mind. The Air Force likes to track program cost. They want us to prove the value. They want us to say, hey, what are you improving for the Air Force? So ACC, or Air Combat Command, a MAGCOM within the Air Force, has a lead team member who's gathering data on a lot of these areas to try to say, hey, this is where we're making a difference for these pilots. This is where and it's hard to prove over the long term, because one of our goals is to keep pilots in the Air Force so that they keep doing their job and not leave, and that's hard to prove in the short term, right? But we do have some areas that we're tracking and measuring and comparing with prior data to see, hey, are we making a difference? Well, are we making a difference? We have some short-term data as well. And it's modest, but it is there. We're seeing between 5 and 10% reported increases, improvements in level of pain in the shoulders, neck, back, those types of things. And I think those are important too. Even if we don't have a lot of data that's peer-reviewed and double-blind studies, we do have some data that's reported from the pilots that says, hey, this is helping me. And I think perceived improvement is important in these operators. Just go through one case with you. And keep in mind, this is pretty common. We have several of these a year that happen, probably, different injuries. This one happens to be a 40-year-old F-35 pilot. His call sign is SLAM. He has 4,000 flight hours. To put that into perspective for you, if you have 5,000 flight hours in a fighter jet, you're in the top 11 pilots in the country. So SLAM has a lot of experience. He's a very knowledgeable pilot. He's got intermittent low back pain for the past 5 years. In November of 21, he slipped on a stair while he was carrying one of his children and felt something give in his low back, very low back, in kind of the buttocks region. And this kind of persisted. He said it was a little bit different than his normal low back pain. So he went into rehab. He worked with the OHWS team a little bit, and it was getting a little bit better, but not all the way. He came in to see me. I gave him an ultrasound-guided SI joint injection, sort of diagnostically, therapeutically, to see if that would help, see if that was the cause of the pathology. It did help a little bit, but not very much. To me, that indicates that it's probably more systemic effect of the steroid than anything. And then again in January, he had another ER visit from debilitating pain without any precipitating event. We got an MRI from there, and we were cautious with getting MRIs in pilots because MRIs are very sensitive. They show a lot of things that may or may not be clinically relevant in them, and it has implications for them for their career. So if someone has a herniated disc on an MRI, they have to be grounded for a good period of time and have to get a waiver to be able to even fly again. So if someone gets an MRI, we have to deal with the results per Air Force regulations. And he happened to have one. He had a big herniated disc. And we set him up to see Dr. Acoin here in town, and he had surgery on January 24th. Then the work began for SLAM. He started rehab really even a couple days after surgery, or a week or so after surgery. He had several visits with them, and then he engaged in a home exercise program, and we all talked, right? We had smooth transitions between the MRI and the surgeon and the athletic trainers, and we made sure that SLAM was on track to make a good recovery, and he did. He did awesome. In fact, he was returned to flying status, went back to flying F-35s within 90 days, which is the Air Force's minimum for this particular injury. What were the keys to his success? Again, he had immediate access to skilled care, he had good transitions, and probably more than anything, he was a motivated patient who trusted the care team. And all these guys are. They're motivated. Some of them don't trust us, some of them do, but they're all motivated because they want to do what they love to do. They want to go fly jets, they want to do the fun stuff. Here's a quote from SLAM, I'll let you read that. I think we're making a difference in the pilots' lives by these programs, specifically here at Hill with the OHWS program. We're making a difference on how they perceive medical treatment. We're making a difference on their access to care, and we're getting them back sooner. We're still yet to prove a lot of this as far as proof of concept with big numbers, and we'll continue to do that. We'll continue to measure these. We'll continue to watch and see what happens with these. But I've been fortunate enough to be a part of this. I'm by no means the organizer or the lead or the developer of this. I'm just kind of a cog in the wheel at our base. But it's been awesome to be able to be a part of that and see the success stories that we have. Thank you for your time. It's been a pleasure to be here. The OHWS programs, like I say, have been instrumental in changing how we treat our pilots. If there's any questions, I'm happy to answer those now or stick around afterwards, and we can have one-on-one conversations and make some connections. Thank you.
Shout, okay, on missions, early in your it is on. It is on. No? I can shout. I'll shout. Okay, early in your talk, you talked about missions where there were these missions may last. I'm going to ask you again how long some of these longer missions last, and how many times the plane, the fighter, would need to be refueled in a single mission before returning to the ground. Got it?
Yeah, if you didn't hear the question, he asked me to talk about how long the sorties last again, the missions that they go on, and how often they would have to go behind a refueler and take more gas on. An F-35, it can go between 1.5 and 2 hours without having to refuel. So in an 8 to 10 hour mission, they might refuel 5 to 7 times.
Is the program available to reservists?
Yes, we actually do have a reserve unit on the base in the 419th Fighter Squadron with F-35 pilots as well. And so that program they have full access to that as well. Good question.
You mentioned about referring out, which I assume you guys do a lot of. Do you have a network that you refer to, or do you just leave it up to, you know, whatever insurance the person has? Or maybe, I don't know if all the people you work with have the same insurance or different insurance, or if you have a certain network, or do you just leave it up to the person, the individual?
Yeah, thank you. Good question. All active duty members and reserve members who are on active orders fall under the TRICARE insurance network. So that's cumbersome for us, and I think it's cumbersome for you as you see our patients, because TRICARE is hard to work with in some ways, and from my understanding, I don't deal with the financial side of it very much. I kind of stay in my bubble, but my understanding is they probably don't reimburse all that well either. And so every pilot that we send out, if we go through the normal process and don't streamline that transition, it goes off into the ether and says, okay, TRICARE will assign them a provider in the network, and that could be anywhere from Salt Lake to Logan, and sometimes they have to change providers, or they have to mitigate the errors that come over time with TRICARE's database of providers. So yeah, if programs like this allow a little bit more personalization between myself and the pilot, I can say, okay, you have an ACL tear. I know that this orthopedic surgeon is a sports medicine specialist. I've talked with him personally. I know he's done tons of these. So I can shortcut that system a little bit and say, hey, I want this particular pilot to see this doctor, and we can set that up and make a phone call and do a smooth transition. But if we don't have that in place, it's much more difficult. So good question.
Is there a mandatory retirement age for pilots, and what's a typical career span of Air Force pilot?
Yeah, also a good question. Thank you. So the pilots are generally get through an undergraduate degree before they start undergraduate pilot training. Undergraduate pilot training, so when they start, they're between 22 and 25 typically. The cutoff to start pilot training, if I remember from the rules, is 29, waiverable up to 30, and they can get exceptions to policy, but about that range is the cutoff to where they can start. As far as how long they can fly, I'm not sure that there is a top limit. There is in the FAA, you have to stop when you're 65, but as far as Air Force goes, I don't think we have very many pilots who are over the age of 50, 55.
Yeah, if they're flying 11-hour sorties, how do you manage relieving yourself in such a small space?
Also a good question. It's very difficult. I have about maybe a couple hundred hours in the back of an F-16, and I've only had to do that a few times because most of my missions were short. But they have, they call them piddle packs. It's a sealable plastic bag that has silicone gel in it, and they basically have to relieve themselves through that. They have to kind of unbuckle a little bit and use that. And in a 10-hour sortie, especially because they've been hydrating well, they'll fill up 6 or 8 of those piddle packs.
You talk on the difference between males and female pilots and how you treat them differently from a physical and a mental status?
Yeah, good question. This maybe a little bit more nuanced one to answer. First off, I guess I'd say that the percentage of female pilots is low. We have in our squadron probably 2 out of maybe, I take that back, probably 4 out of 30 pilots are female, and they excel. They do awesome. Our female pilots are accepted in the community. They're well received. They contribute. They're some of the best pilots we have. As far as a health standpoint, for me as a sports medicine physician, many of the same things that non-pilots we would kind of treat differently. Females may be more susceptible to certain injuries. As far as women's health care, we do have a women's health clinic on base that we can send people to and get regular women's health care for them. They do have, alluding to the prior question, they do have specific systems for relieving yourself in the jet for females rather than in males. So those are accommodations that haven't been around very long. We didn't really think about that for some reason until the past 10 years. Like, oh, maybe that anatomy is a little different. We should probably try something different. But there are differences in how we take care of them and how we treat them as far as taking care of them. But nothing too significant. Other questions?
How about DVT mitigation or prevention?
DVT prevention, we don't implement anything specific. Besides, I tell my pilots, hey, when you're up in the jet for 10 hours, try to stretch your legs out, move the rudder pedals forward. If you can move side to side a little bit and initiate some sort of movement. So far, I haven't seen, the only DVT that I have seen so far in my F-35 pilots was a post-surgical one that happened not too long ago. And that had a precipitating event from surgery rather than flying. But other than that, I haven't seen it. Good question.
How about relieving in terms of bowel movements? I mean, 11 hours is a long time. Do they anatomize ahead of time or anyhow? 11 hours is a long time.
It is. Yeah, thank you. We as flight surgeons prescribe medicine for them. That's the short answer. Imodium, we give them Imodium. I tell them not to take 2 at a time because they'll be backed up for a few days, but they use them on a regular basis because they don't want to have, there's no way to do that in the jet.